Welcome to episode 10. Today's going to be a special video edition of Beyond the Thyroid podcast, and we are going to do a deep dive on lab tests for hypothyroidism that I use in my practice. So, we are going to go over what the different reference ranges mean, what levels are ideal, and how I put the information together to design a custom treatment plan for my patient, of course, which thyroid tests I order in the first place. Then we'll finish with a few tips on how to make the labs you do get more accurate and helpful to guide your treatment. So this is an integrative approach that was developed initially by my mentor and that I refined over nearly 30 years in practice. And it allows me to get far superior results in fixing people's energy levels and their other thyroid symptoms quickly, while they also work to get their Hashimoto's disease and other triggering conditions under control. It's much easier to optimize your diet, habits, and lifestyle once you're not exhausted all the time. So let's get started.
You're listening to the Beyond the Thyroid podcast. I'm your host, Dr. Dana Gibbs. I'm an ENT surgeon and hormone specialist. For years, I struggled with my own unrecognized thyroid problems before and even after I was regularly performing thyroid surgeries. Then, one day, I learned something that turned my health around and opened my eyes to the limits of mainstream medicine in treating more subtle thyroid abnormalities. I spent the next 20 years fine-tuning my hormone expertise in disorders like Hashimoto's disease, perimenopause, and stress-related illness. Come join me as I share this new approach to hormones that empowers you to take control of your own thyroid and hormone imbalances. Let's dive in.
Hello, my friend. I am happy you are here with me for another week of diving deep on thyroid balancing. And if this is your first episode, welcome. This week, we're going to build on some knowledge from prior weeks. So if you find the information today a bit overwhelming, you might want to go back and check out episodes 1 and 2, where I start with really basic information about thyroid function. And before we dive in, if you've been listening a bit and enjoying the content, I have a favor to ask you. If you could, please consider leaving us a 5-star review. Every review I get helps more people who need this content badly find it when they search. It's really easy. Just go in your podcast app, click on the show, scroll down, and click leave a review. And I read and appreciate each of you who comment. So now on to today's topic. And I did mention this is a video edition. So if you want to look at the slides that I'm going to share in a little while, you can find this on my website and on my YouTube channel, which is danagibbsmd.com. So in episode 8, we talked about 3 ways that hypothyroidism shows up as relates to the traditional labs that are done by most doctors. So the regular way is with high TSH. The second way is with subclinical hypothyroidism, where TSH is barely elevated, but the doctors tell you there's nothing to be done because your labs are otherwise fine or they're not bad enough. And then the third way is where all your labs are technically in the reference range, but you know something's wrong and it fits hypothyroidism clinically because of the symptoms that you have. This is one of the most often missed by mainstream medicine because, well, all your labs look normal, at least at first glance. So each of these types of hypothyroidism, even if treated with the traditional treatment, can leave you feeling flat and without resolving your symptoms, even with labs that look normal at first glance. And all 3 of these types can coexist with Hashimoto's disease as it attacks the thyroid gland or occur for an entirely different reason. They can also coexist with many other disease states like food allergies, insulin resistance, or other inflammatory states that can make you feel terrible. So how do I figure this out for people? Well, it's by the labs. And this week we're going over the thyroid function labs in detail to show you how they all fit together, a bit like a jigsaw puzzle, to tell a story that allows for recognition of a thyroid balance, even in the face of what seems like normal labs at first, and to help guide a treatment that's actually effective at making you feel better. So the system I use is based on the nuances of thyroid hormone metabolism as influenced by your lifestyle, your exposures, your diet, your immune system, and it's science-based and it's accurate. It's far more accurate at figuring out your thyroid function than the standard way of reading tests. It's also more accurate than the vague way that many functional practitioners try to treat thyroid by guessing at what's actually wrong and if or how much medicine to recommend by following people's body temperature and heart rate. That is super old-fashioned and may have been fine when the labs didn't exist, but it's not really good now. I also hear person after person saying they don't want to take any thyroid medicine, even while they're really suffering. And I don't blame them, seeing how there are so many stories out there of people who feel like their thyroid medicine makes them feel worse, while their labs are either fluctuating up or down or make no sense compared to how they feel. But thyroid medicine is just another tool we have in our thyroid treatment toolbox. And while some people will have to take it long term, many will not. So when they're combined properly and followed with the correct lab technique, it's more effective than anything else I've found at helping people quickly get their energy back. More than just getting by, my patients regain their vitality and their energy so they can start right away on unraveling the deeper causes and fighting the inflammatory process that are triggering their hormone imbalance in the first place. Building muscle, stopping bone loss, eliminating bloating and weight gain, and sleeping better are all benefits of getting your thyroid back in balance. So I've even had people resolve long-standing infertility problems just by getting their thyroid hormones correctly balanced. All right, so how do we do these labs in a way that tells us more? So how I start depends on two things. One of them is, are you already taking thyroid hormones or not? And two, do you have an autoimmune thyroid disease diagnosis or not? So remember, just because Hashimoto's is the most common cause of thyroid imbalance, it doesn't mean it's the only cause, and you can have more than one at a time. So first of all, let's talk about thyroid labs or normal labs without medications. And we're going to talk about the TSH test first. So TSH first. TSH is the brain trophic hormone that signals the thyroid gland to produce more thyroid hormone. So if it's high, it's telling you that you don't have enough. But there are reasons why it might not be high, even when you're symptomatic with hypothyroidism. The first and most dangerous reason is that you have a pituitary tumor that's stopping the TSH from being produced in the first place. So anybody with low TSH and low normal thyroid hormone levels should be checked for this. So low or normal TSH in the face of inadequate or unbalanced thyroid hormone levels can occur for other reasons as well, mostly to do with stress or genetic variants in the enzyme that makes T3, the 5' deiodinase type 2 that I've discussed in previous episodes. But anyway, just know that the TSH can be high normal or low normal or even low, and it doesn't say much about your actual thyroid hormone levels, whether they're in balance or not. That said, let's talk about where the TSH should be if all else is good. So I think the actual reference range, as reported by the labs, usually around 0.45 to 4.5, is way too broad, even after the reference labs lowered the normal range several years back. So my ideal for TSH in someone who's not on medications is about 0.8 to 1.2. So let me show you this on a slide really quick. So for some background on labs, I want to explain really quick how the reference lab decides what the range for any lab ought to be. So actually what they do is they take a representative sample from each of a large group of normal people. And I'm just making this one up as an example, but say they used all the thousands of employees of LabCorp who answer a questionnaire and then get their levels tested. And then they take the mean of all those numbers, meaning half the people were above and half the people were below a specific number. In the case of TSH, it was about 1.5, and they cut off 5% of the numbers, half from the bottom and half from the top. And they exclude those outliers, and then that's the reference range. So the terminology is 2 standard deviations from the mean. In this case, they came up with a reference range of 0.5 to 2.5 in the story that I heard. But because of politics and because of the fact that about 50 million more people would be classified hypothyroid if they used that, they decided on 4.5 as the upper end of the reference range. So that's 1,000% increase from the lowest number to the highest number. How can that possibly be correct? It may be all right to use a technique like this when an abnormal lab is pretty uncommon, but in a nation where over 10% of the population has known Hashimoto's antibodies, it feels like the methodology is kind of flawed to me. So you can see how this can be a problem in common diseases by looking at the example of diabetes. Almost 15% of adults in the USA have type 2 diabetes, where the defect is insulin resistance. So you can easily measure the fasting insulin level and tell if somebody's trending towards diabetes by that number. But 40% of quote unquote normal adults have insulin resistance. So if you're using the 2 standard deviations, 95% technique, to set the reference range for fasting insulin, you get 2.6 to 24.9, when most doctors who are in the know realize that anything over 7 on an insulin level is known to have a high risk for diabetes. So if your provider doesn't know that, then how does that lab test even help you? They don't know that the real top of the normal range ought to be 7. So that's diabetes. But thyroid labs are pretty much the same, and TSH is only the first example. My personal opinion is that anybody who has a TSH above 2.5 or even 2.0 ought to get a deeper look if they have symptoms of low thyroid. And high cholesterol is a symptom. So I don't care what the TSH is, I'm always going to get more labs than that. Next, let's talk about T4. So T4 and T3 are the 2 main thyroid hormones, and they are made in and dumped out by the thyroid gland. They're also stored in the thyroid gland, but they circulate in the bloodstream mostly bound to proteins. So for T4, 99.7% of what you have is bound by proteins, and only 0.3% of the T4 in your blood is free from the binding proteins. So why do we have binding proteins? Well, a couple reasons. Protein helps fat-soluble hormones dissolve in your blood, which is water-based, so that it can go easily in and get to all the target cells in your body and do what it does for your metabolism. Protein binding also helps the thyroid hormone stay in your system longer, so it isn't filtered out by your kidneys, which if it was free from the hormones, it would be filtered out. And it's very interesting to note that the binding proteins can vary a lot in your body based on what else is going on with your metabolism. Is your liver healthy? What part of your menstrual cycle are you in? Perimenopausal, insulin resistance, what medications do you take? And how much thyroid hormone you have. So all these factors change the levels of binding proteins that you have, which then changes the amount of free hormone you have available to your cells. The higher your binding protein, the lower amount of free hormone you have. So the reason it's important to keep this in mind is that modern thyroid hormone tests can either test the total hormone amount or the free hormone amount, the part that's not bound to the proteins. So you can measure total T4, or you can directly measure free T4. And the most modern version of free T4 testing has only been around since about 2010. And many doctors are still using the very old test, the free thyroxine index, which estimates the free hormone, even though it's completely obsolete. This was a way of calculating the free T4 by trying to estimate and divide out the binding proteins so that you're left with that ever so tiny percentage of residual. Anyway, free T4 is the amount that's available to be transported into your cells and converted into the active hormone in your cells at any given moment. And this is the number I follow, free T4. But here's the thing. People, particularly doctors, have this idea that free T4 is a pretty stable number. And if you have Hashimoto's disease, your thyroid is releasing your T4 in bits and spurts. So the level can actually fluctuate quite a bit. And that fluctuation, particularly the rise, can drive the suppression of both free T3 production and your TSH and increase the amount of reverse T3 that you have. So my ideal level of free T4 in a person is actually right down at the lowest end of the normal range, the reference range, which is currently 0.82 to 1.77 at LabCorp. So I like free T4 to be between 0.7 and about 1.3 in somebody who's not taking thyroid medicine. When I see somebody who has a free T4 that's higher than that, I will immediately suspect that they're going to have reverse T3. And higher is generally not better when it comes to free T4 in those situations. So the highest I like to see is 1.2 to 1.3. And that only applies if the person is not taking thyroid hormones. Next, let's discuss T3. So T3 and then reverse T3 are both made in the thyroid gland and come out of the thyroid gland at about a 10 to 1 ratio, same as the ratio between T4 and T3. And if everything's going well, that ratio stays that way, or the T3 is actually higher than a 10 to 1, maybe a 12 or a 14 to 1. So your body cells also use the circulating T4 to make either T3 or reverse T3. And about 80% of the T3 that your body needs is actually produced in the cells from the circulating T4. So I test free T3 and total T3. We talked about those two and what it means to be total or free, but free T3 tends to be around 1% of the amount of total T3. So the free hormone level normally exists in a pretty tightly controlled range, whereas the total T3 drifts up and down based on how much binding protein is present in your body. So changes in these binding proteins do occur in each person with their menstrual cycle, with sex hormone replacement, with pregnancy, with birth control pills, and some other situations. So a calculated free T3 is a very complex number to achieve because of those variations in the levels of the different proteins. And once again, the direct test for free T3 is readily available. So the obsolete way of calculating free T3, which is called T3 resin uptake test, is not needed. And most people feel best at a level of about 3.3 to about 4.2 when the full normal range of free T3 is 2 to 4.4. So the reason I need the total T3 is so I can compare it with reverse T3. And this comparison gives me the single best way that I can evaluate the balance of hormone activity in the body, because these two hormones compete for and occupy the same receptors in the nucleus of every body cell. The T3 activates the receptors, and the reverse T3 doesn't actually do anything but keep the T3 from binding. So because reverse T3 is present in your body in such small amounts, there is no test sensitive enough to test for free reverse T3, which is how I would like to compare it to the T3, but I don't have that test. So it would be below the lower limit of detection, even on the high-tech equilibrium dialysis, which is the most modern type of thyroid test. So the available reverse T3 test only gives us the total reverse T3, even though it's not labeled that way when you order it. So because it's a total number and because the binding proteins can vary so much, the normal range of reverse T3 can vary hugely, and it's listed as between 9.2 and 24.1. Of course, anything above that normal range is an indication of a very disordered thyroid function, and a reverse T3 of below 7 is also not great, and that person will not feel well either. But the best way to know about the relative importance of reverse T3 in any one person's body is to compare it directly to the T3. And there are a lot of functional medicine doctors that claim to be able to do a calculation with the levels of those different binding proteins in order to compare reverse T3 with free T3, or maybe they just eyeball it, who knows. But there's a much more useful way to interpret this test. So when you test reverse T3, the most helpful way to use it is to compare it to the total T3. The binding affinities of these two, the reverse T3 and the T3, are close enough percentage that it makes it a meaningful apples to apples comparison. So a total T3 divided by a reverse T3 makes a simple ratio that's easy to interpret. So 12 to 1 is perfect, and the ideal range is 10 to 14. And if it's above about 17 or 18, it means either your T3 is too high or your reverse T3 is too low. And because you need some level of reverse T3 in your body, it's not going to feel good to you. But if that ratio is less than 10, then you have less than ideal thyroid function, and then your symptoms will be hypothyroid. The lower it is, the worse you generally feel. And that's it. That's the magic test. So those two tests, along with the TSH, the free T3, and the free T4, are the complete basic panel that I follow for my patients with any health status or med change. So if a patient has never had autoimmune thyroid antibody testing done, and they have symptoms that can be attributed to thyroid, I generally recommend that the antibody test be done as well. And I generally follow the reference ranges pretty closely for those. And you can repeat them, though I don't really feel like it's necessary to redo those very often, unless you wanted to check the status of some intervention that you're trying to do to lower antibody levels, and you can't tell because there hasn't been a symptom change. So next, I want to do a patient who's already on thyroid hormone replacement, because it does change my ideal levels up a bit. So my range of acceptable TSH and T4 numbers are much tighter and much lower in someone who's taking thyroid hormone medicine than someone who is. Unless we are purposely suppressing their thyroid for some very specific reason, for the TSH range I go to tends to be at the bottom end of the reference range. So about 0.5 to 0.8 for somebody who's on treatment. The reason I don't like to see the TSH number get too low is that it indicates that we're probably overdosing that person on thyroid medicine, and there are adverse effects for doing this, like bone loss, hypertension, and heart damage, even if they don't notice the immediate side effects, which are irritability, weight loss, difficulty sleeping, and some others. So for the T4 level, if someone's taking thyroid hormone, the ideal for me is between 0.7 and 1.0. And yes, I realize that that's a little bit below the reference range. It goes off the bottom of the reference range a little bit, but I decide how much T4 to give someone or how to change their medication dosing depending on a balance of all the numbers. So if the lab comes back and the free T4 is only 0.7, but they still have elevated reverse T3 and their reverse T3 ratio is below 10, I will increase the T3 supplementation instead of increasing T4. Now, if the ratio is looking good and it's above 14, then I might increase their T4 dose as long as their TSH level is high and not lower. If their TSH level is below normal, then I might not raise the T4 at all. And of course, I'm most interested in how a person is feeling once I've had them make medication change. Now, I did mention in an earlier episode how I like people to time their lab tests. And this is super important no matter who your doctor is. I recommend that all thyroid medicine be divided and given at least twice daily, no matter which brand or which type a patient is taking. And then I have them get their lab draw halfway between the morning and the evening doses to get a best idea of where their levels are on average. So that's 6 hours after your morning dose if you're taking your medicine every 12 hours. So you don't want to get your blood test tested at your lowest level of the day, which is before you took your meds in the morning, or even lower, which is what you have if you have a patient hold their morning meds and then get tested after 24 hours after their last dose of medicine. This will give us a level that's below even the lowest level that they normally see all day, because it might have been 27 or even 30 hours since their last dose. And that is bad enough with levothyroxine alone, because it triggers your doctor to probably overdose you. And with levothyroxine, where the hour-to-hour levels fluctuate around 30% or more, that's even worse. But if you do that with T3 containing meds or liothyronine or desiccated thyroid, the blood test can show less than half of what their actual average level is. So this leads to potentially dangerous overdosing. And it's also generally noticed that in those folks, they will have an extremely low TSH and frequently have telltale symptoms of overdosing, which I mentioned earlier. There's also a couple more little picky details about lab testing that I want to point out before we sign off. So there are different kinds of thyroid tests. Most thyroid tests are done with a kind of test called an immunoassay. And immunoassays are subject to contamination. The most common contaminating ingredient is something called biotin. And biotin is a B vitamin, and it is very, very commonly taken in extremely high doses by people with low thyroid, because it's reputed to help improve your hair growth. And while I'm not convinced that that even works, having higher doses of biotin in your system when you go get your immunoassay test means that your thyroid hormones are going to look way higher than they actually are. There is one other thing that contaminate an immunoassay test, and that's something called a heterophile antibody. And heterophile is an antibody that can come up when you have various viral or bacterial infections recently or in the fairly recent past. You can have elevations of heterophile antibody. And if you don't know you have that, then your thyroid test can look normal even when you're really, really low. And so if you get a test that doesn't make sense, what you need to do is you need to go back and ask for the test to be redone in the more high-tech way, which is something called liquid chromatography mass spec testing or equilibrium dialysis testing. And I'm not super clear on exactly how those two tests are different, except that they don't rely on antibodies to do the test. And so there's no interference by biotin or those other antibodies. One other thing is that eating a lot of soy isoflavones in particular, can transiently raise the level of reverse T3 that you have. And so it's not advised to be eating soy isoflavones or unfermented soy. I don't like my patients to do it at all, but particularly around the time of your lab test. So 3 to 4 days without that before you get your lab tests. You also want to watch out for supplements that contain another thyroid hormone metabolite called T2. So T2 can make your thyroid hormone levels better than they are, because it can drop your TSH, even if your T3 and your reverse T3 are low or not in the correct range. There's also no commercially available lab tests for T2. And so you don't need to take T2 if you're getting enough T3 in your body. And so I strongly don't recommend people to take T2. All right, so that is all I have for you today. Thank you so much for listening. I realize this was super dense science-wise, but we are going to talk more about how I balance labs next time. And thank you very much for listening to Beyond the Thyroid.
Thank you for listening to this episode of Beyond the Thyroid. If you found this information valuable, it would mean so much to me if you'll take a few seconds and give the podcast a 5-star review. It helps other people who need this information find the show, and it's really easy. Just search and click on the name of the show, Beyond the Thyroid, and scroll to the bottom to ratings and reviews. I truly do read and appreciate every one. Remember, when it comes to hormones, there will always be more to discover. So follow the show so you get the next episode as soon as it's released. And if you or someone you care about needs a caring doctor to help figure out how to heal hormone problems that other doctors have dismissed, check out my website at www.danagibbsmd.com. And if you're not a physician, please keep in mind, while I'm a doctor, I'm not your doctor. The content of this podcast is my opinion, and it's for educational and entertainment purposes only. This is not meant to be individual medical advice, and you should consult your own physician for any medical issues or diagnoses that you may have. I look forward to continuing this journey with you beyond the thyroid.